Good morning, everyone. Thank you, Scientific Committee, for the opportunity. So we all know why a GDD fails in the long run. It's mainly because of the encapsulation of the fibrous capsule surrounding the plate. We have already seen the options: diode, another tube, or we can just revive the first tube by needling or MMC injection, or as demonstrated, blood ball excision. Now we have the option of GAT also. If you have a spare conjunctiva, you can also try TRAP, or you can just refer to someone else. Since we have different options, it is so clear that there is no clear consensus on the management after a failed GDD. So before going to the second tube, this decision depends on the other eye status, the patient's understanding of the disease, the location of the first implant. So if you have a supratemporal one, you can also try an infranasal implant later, and also the prior surgeries the patient had. Of course, the status of the sclera. So this is one patient who had extensive scleritis, so we cannot plan tube in this quadrant if you're planning the second one. It also depends on the status of the cornea, the anterior chamber depth, and the prior implant complications, whether the patient had any plate exposure or tube exposure. Above all, the potential for vision. So when you're planning the second tube, it's important not only to look at these spaces, but also look at the elephant in the room, that is the tube in the anterior chamber. If you already have a tube in the anterior chamber, the second tube, if you're making the decision, you should be careful. You don't want to compromise the cornea. So again, this second tube decision is dependent on all the prior complications that you have had in that eye. So capsule excision, this is one study which is really old. It was found to be effective in about 75% of the cases, but it is difficult. We know that it's bleeding is an important issue, and of course the blood ball comes again. So what about shunt revision versus additional tube implantation? So this was a retrospective study. They had good results at 2 years. The main complication, as expected, the second tube was corneal edema. But the one problem with this study is, so there were no standardization for the second implant. If you had used Barwell, the second implant can be AGV or Barwell. So that was not standardized in this one. So if you're planning a second tube, what tube to use is not, we don't have a clear idea as to what has to be used. So what about children? So we are mainly worried about children because they are the ones who have a long life, and they are the ones on whom the tubes will fail. So this also found reasonable success with the second GDD, where in most of the cases, the first GDD was an Ahmad implant. But the catch here is most of the eyes will need a third intervention. So it is not like everything will get over with the second tube. So coming to diode, so diode is a good option, but this debate is only about excision and tube, but I'll just cover about diode also. So failed GDD, you can try diode also. This study is interesting because the second tube had good initial success, but the CPC had late failures, relatively low late failures. So this is one RCT which compared second tube versus diode. So relatively both were okay. As expected, GDD had more clinic visits and risk of additional glaucoma surgery. So after failed options, after a failed GDD, both were reasonable options. So you should know when to stop. So though I'm talking in favor of second tube, but if you have a bad cornea and a bad conjunctiva, don't just go for second tube. It is better to stop with diode. So too many tubes are not good for the cornea. If at all you're planning a second tube in an eye, if it's a pseudophakic eye, always put the tube in the sulcus. Do not put the second tube in the anterior chamber. So we have to remember all glaucoma surgeries fail, of course, with time. So above the glaucoma progression and IOP, consider the patient's quality of life before advising any surgical intervention. Thank you.
Thank you, Dr. Prasanna.